proceed.
Isha, are you able to unmute?
Okay, cool, perfect. Hi, can you hear me?
Yes, go ahead, Isha.
Okay, perfect. All right, so yeah, my name is Isha Mkoki, and with my colleagues Zahra Mohammed and Elaine Forshenke, we'll be presenting about pediatric HIV in primary healthcare. I can't see the screen. Okay, there you go. So just a bit of background to talk about the numbers with regards to pediatric HIV. The latest stats we have are from 2018 to 2019. And at that point, there were about 160,000 children below the age of 10 who were newly infected with HIV, bringing the global total to about 1.12 million children living with HIV. And with adolescents between 10 and 19, those 190,000 adolescents who were newly infected with HIV in that at that point. And the total for the year was 1.65 million adolescents living with HIV. And that gave us a staggering number of about 115,500 deaths, age-related deaths in the world at that point, occurring in people less than 20 years of age, which is quite a large number. It's about 15% of all the age-related deaths at that point in time. And unfortunately, given false circumstances, about 90% of those children living with HIV and AIDS currently live in sub-Saharan Africa. And just to talk about how these children tend to get infected with HIV, the bulk or the majority of these transmissions come from mother-to-child transmission, which is over 90%. And this is usually in pregnancy, intrapartum, and during breastfeeding. About 10%, or less than 10% rather, comes from sexual contact. And just to be aware in this state that it is possibly, risky behavior and consensual behavior between adolescent children, but this could also be as a result of sexual assault occurring and resulting in infection of these children in this case. And lastly, a very minute percentage get infected with blood products. So this could be blood transfusions, or in fact, getting infected by blood products from their family members or even healthcare workers while doing procedures, as the previous team was talking about. But a great success we've had with HIV prevention has been with prevention of mother-to-child transmission, having halved the incidence of HIV positive cases or new pediatric HIV positive cases, should I say, between the years of 2010 and 2018. So now just talk about how we make the diagnosis of HIV in pediatrics. This slide is a lot, but just the take-home points here are that you need to conduct age-appropriate testing for children that you're concerned have been perinatally infected. So you might know the mom is HIV positive or suspect that the mom is HIV positive or the child is positive based on the clinical picture. And in terms of age-appropriate testing, below the age of 18 months, the recommendation is to do PCR testing. And between 18 months and 2 years, you can do an initial rapid test and a confirmatory PCR test. And particularly of note in this age group is to consider children that are still breastfeeding. So if the child is still breastfeeding, then you definitely want a PCR test confirmatory, because the maternal antibodies can cross over through the breast milk into the child's system. And also just in there with greater than 2 years of age, we do need 2 confirmatory rapids as with adult testing. But those are just the main take-home points there. And just another thing that they mentioned there is that you should you get a confirmatory test, you shouldn't wait. Sorry, you should get a single positive test. You shouldn't wait to initiate it before getting a confirmatory test. So yeah, so now that we've made the diagnosis with the 2 tests, what next? So an important and very seldom considered part of this procedure is informed consent and disclosure from the caregivers where children are being tested. So informed consent must be obtained, and where the child is greater than 12 or of sufficient maturity, counseling can be given to the child, and informed consent obtained with the assent of the parent to testing, and also then post-test counseling is essential as standard. And just another thing that we need to understand, particularly with pediatric HIV, but also applies to adults, is that disclosure is an ongoing process. And at every visit, you should aim to have an ongoing discussion with the family or with the caregivers and the children where they're sufficiently mature about their mental, emotional, and physical well-being, as well as the understanding of the disease and how they're coping with this. So we aim to start early. So it's understood that between the age of 4 and 7, a child begins to understand the concept of medication and that relationship to their well-being, and how taking medication can have a positive effect on their body. And as the child goes, you go from what we would call partial disclosure, based on the child's maturity and understanding of disease and disease function. So you can start from explaining the child, say at the age of 4, explain to the child that they are taking medication because it's good for their body and it's going to make them strong. And as they grow, you can start explaining to them the concept of the immune system and, describing perhaps their white blood cells as, soldiers that protect the body from infection. And, considering calling the virus baddies, or, explaining to them that the medication that they have or that they need to take is for their benefit, and it is meant to help strengthen the immune system. And ideally, you want to reach a stage of full disclosure, i.e., this is fully disclosing the name of the virus to the child and the consequences thereof between the age of about 11 and 14. Also, just to understand that this is this is something that you want to do in collaboration with the caregiver. It's not that you disclose the condition to the child, but you want to encourage the caregiver with your support to discourage and have this conversation with their children so that they all understand what's happening. There is also an encouragement to involve all stakeholders within the child's care. So even as the child goes to school, it would be you can consider encouraging having the teachers aware of the child's condition, understanding the potential drawbacks of the stigma that could be associated with this. But again, like I said, it's an ongoing process that you have with the family, the caregivers, as you continue with every consultation for the child. And yeah, I've already mentioned that you want to have this discussion as the child continues to grow. And once they reach a stage of full maturity, you also want to disclose their rights and responsibilities regarding HIV in terms of their disclosure, and also their responsibility to prevent future infections, whether horizontal or vertical transmission going forward. And yeah, I'll hand over to my colleague here to speak a bit more about the clinical evaluations going forward.
All right, so when you diagnose HIV, you need to start with baseline clinical and laboratory investigations. Elaine, have you changed the slide? Okay, great.
Yes, I have. Sorry, I think there's a delay.
Okay, that's fine. So part of baseline clinical evaluation is a nutritional assessment. So in adolescents, you'll use the BMI. In children, you'll obviously need to plot on the growth chart and assess for malnutrition. So you'll use the Road to Health card for that as well, to see how they've been growing, look at trends and so on. You want to screen for TB in children. You'll screen for symptoms of meningitis, headache, confusion, visual disturbances, and so on. Mental health as well, so especially in older children and adolescents. And this includes depression, but also things like psychosis and substance use should be mentioned there. And then chronic diseases, and in children we're specifically thinking also about epilepsy because of drug interactions with anti-epileptics and ARVs, and then to screen for pregnancies and STIs, obviously more in older children and adolescents, and to do a neurodevelopmental screen. So the general things that you should be doing anyway with when you see a child. In terms of baseline laboratory evaluations, the main things are CD4 count, hemoglobin, and gene experts. So the CD4 count, it differs depending on if they're less than 5 or more than 5. If they're younger than 5, you look at the percentage, and I'll show you a slide. The next slide touches on why we do that. And then if they're older than 5, you use the absolute count as with adults. The HB, if they're less than 5 years, if they have a low HB, you just treat with iron supplements and deworm. If they're over 5 years, you do it as with adults, do an FBC and characterize according to the MCV. And then you do a gene expert only if the patient has a positive TB screen. So I think, for example, in pregnant women, we do gene experts, should be doing gene experts on everybody. But in children, we only do it if there's a positive TB screen. So the next slide just looks at the CD4 count and why we're using percentages. So if we just look at what not virally suppressed means in the different age groups, less than 12 months, it's over 1,500. 1 to 5 years, it's over 1,000, and 6 to 12 years, it's over 500. So that's basically the reason that we're using percentages when they're younger compared to absolute CD4 counts later. Next, okay, so in terms of cotrimoxazole preventive therapy, it differs depending again on the age group. So this is straight from the guidelines, the 2019 guidelines. If the patient is under 1 year, they need to be on CPT irrespective of their CD4 count. You don't start it before 1 month. So basically any diagnosis from 1 month to 1 year, they need to be started on CPT until at least 1 year. Between 1 and 5 years, you only start them if their CD4 percentage is less than 25%, or if they have a higher clinical stage, so stage 2, 3, or 4. And then you discontinue if the CD4 count increases to over 25%. Importantly, also in that age group, at the under 5 years, if they were actually infected with PJP, then you need to start the preventive therapy after the treatment is complete. The treatment part is completed, and you'll continue until they're 5 years old. And then still then after 5 years old, you need to wait for the CD4 criteria to be met in order to stop the preventative therapy. And then in children over 5 years, it's the same as in adults. So CD4 less than or equal to 200, and then the higher clinical stages. In terms of preventing TB, we must remember that actually, regardless of HIV status, children under 5 years old must be given TB INH as prevention if they have a contact of an index TB case. So that's for everybody regardless of HIV status. But then older than 5, it's only if they're HIV positive and they are contacts that you'll give INH. And then just a reminder before we move on to first-line treatment about the major ARV classes. I couldn't attend last week, so I think this is probably repetition from last week's HIV in primary care. But we have the NRTIs, and those are nucleoside and nucleotide reverse transcriptase inhibitors. And I'm not going to go into detail, but basically the NRTIs and the NNRTIs both disrupt reverse transcriptase, which converts the viral RNA into DNA. So it stops HIV replication in that way. And the NRTIs are known as the backbone of first-line treatment. So we'll obviously know them as like tenofovir, lamivudine, and so on, zidovudine, abacavir. The NNRTIs, it's again, like I said, a similar mechanism, but they actually bind directly to the reverse transcriptase enzyme, blocking the process. And those ones, the common ones are obviously efavirenz and nevirapine. Then the protease inhibitors block the activity of the protease enzyme, which HIV uses to break up the large polyproteins into smaller pieces that are needed to make new viral particles. So basically, HIV can actually still replicate in the presence of protease inhibitors, but the variants that are produced are immature and aren't able to infect new cells. So like lopinavir and atazanavir are the ones that we commonly use, and to remember that they need a booster to slow down liver metabolism. And then the integrase inhibitors, obviously we only more in the last few years have been exposed to them commonly. and they target integrase. It's also a protein which is needed for viral replication because it inserts the viral genomic DNA into the host chromosome. So if you inhibit that, then it stops the virus from inserting into the host DNA, into human cells. So dolutegravir is obviously the one that we most commonly would use. Okay, so in terms of first-line regimens, it depends on the age of the child and the weight of the child. And if they don't, the guidelines say that if they don't really fit into these age weight categories, then they generally need to be referred either for example, failure to thrive workup if they are weighing less than 3 kilograms and over a month, for either for that or to a specialist for first-line regimen that's appropriate for both their weight and age. So under 1 month and between 2.5 and 3 kilograms, you give zidovudine, lamivudine, and nevirapine. After 1 month, you'll change the zidovudine to abacavir, and you'll change the nevirapine to lopinavir ritonavir. So lopinavir ritonavir can't be given before 14 days. I think that's the main reason for not starting it from birth. And abacavir also actually isn't registered for for newborns. Then once they get to 20 kilograms, they can be changed to abacavir, lamivudine, and dolutegravir. But for that transition to be made, they need to be virally suppressed in the last 6 months. And then once they are over 35 kilograms and over 10 years, they can transition to adult and adolescent regimens. So basically, you don't give tenofovir if they're less than 35 kilograms or younger than 10 years of age. Elaine?
Just unmute myself. So I'm going to tell you guys more about dolutegravir. So obviously, as Zahra's already explained how it works, integrase inhibitor, and I'll be talking about some of the advantages and disadvantages. So some of the advantages is that it has a high genetic barrier to resistance, which is also why it takes so long to develop a resistance against it. It has minimal adverse effects. I think anyone that's been on PEP knows this. If you've been on an old regimen and then switched to dolutegravir, it's definitely a much better drug to use. And especially in children, this is very, very important for adherence. So then also it has fewer drug interactions. I'll go into the drug interactions a bit later on, and it has rapid viral suppression. Some of the disadvantages, though, is that it still does have drug interactions, most importantly being rifampicin. I'll explain how dolutegravir needs to be adjusted when patients are on rifampicin, but it is very important, obviously, because many of the kids do get TB. And then update on the risk of neural tube defects. As Shiraz and them said last week, it is now safe to use in pregnancy, but the study that was done last year in Botswana indicated that patients who did not use dolutegravir had a 1 in 1,000 risk of having children with neural tube defects, whereas patients that were using dolutegravir had a 3 in 1,000. Although a circular that was sent out on the 29th of June actually updated this, saying that there's no significant difference in neural tube defects. I think the risk difference was 0.12% at that stage. Then also dolutegravir has metabolic effects, which is mostly self-limiting. So the drug interactions, as I was saying, we have some that decreases the dolutegravir exposure. In other words, you'll have to give a double dose of dolutegravir or adjust the dolutegravir to give more. And then you have metformin that increases the dolutegravir exposure. In other words, you'll have to adjust the metformin in that case. Most important being rifampicin, obviously for concurrent TB patients. An issue is actually the polyvalent cations. These are supplements, which most of the HIV children do take. So it's important to know this, because when you prescribe MVT syrup for an HIV positive patient, you do need to understand that there is a difference. It's not like giving MVT to a patient that is HIV non-reactive. And then even more important are anticonvulsants. So if you have a patient that's known with focal seizures, that might be on carbamazepine, phenobarb, or phenytoin, it's important to know that you do need to increase the dolutegravir in those cases. And then here's a nice chart that's also part of the guidelines that we will post on the group. It explains exactly to you how you should adjust dolutegravir or adjust, in the case of metformin, the other drug, in order to have effective viral suppression. So you guys can go through that in your own time. Then some international updates regarding dolutegravir is quite exciting. The FDA in February this year actually has approved the use of dolutegravir in patients under 20 kgs. At the moment, we did speak to our PHC nurses that run the HIV pediatric section at Stratford, and we currently still use obviously just the guidelines. There's not really anyone that uses a different guideline at this stage, which is great. But hopefully this will change in the future. They actually have this tablet called Tivicay. That's a dispersible tablet, and it's wonderful because it's actually given according to the weight of the child. It can be given to anyone older than 4 weeks or weighing 3 kgs or above. The tablet can be broken up. It can be taken with water if the patient struggles to swallow. The dosing, like I told you just now, is according to age and weight as well. And yeah, they have the same drug interaction, so there's no increased risk when taking these formulations. So it is something to think about in the future. Then when we switch patient to dolutegravir, mostly the patient will be on a first-line regimen that includes lopinavir, ritonavir, or efavirenz, right? So obviously, like I said, the patient has to weigh at least 20 kgs, and you have to monitor the viral load very well. So if the viral load is less than 50, you would discuss with the senior to kind of weigh out the risk and benefits and have a thorough discussion with the parents as well regarding this. If the viral load is a bit higher, then you need to investigate first. So you need to do a thorough investigation and make sure the patient is adherent. You need to retest the patient in 3 months. If the viral load is still under 1,000, then you can switch to dolutegravir. If it's over 1,000, then Zahra will talk about virological failure, etc. in the future slides. So a patient that's under 10 years, under 35 kgs, you put them on a bacavir plus dolutegravir. If they're over 35 kgs, you can use tenofovir, no problem.
Okay, so the next part is initiation in neonates. I'm not going to go through it all in detail, but the important things is that there's a lot more monitoring than initiating in older children and in adults. So you review them at 1 week. That's when you'll check blood results and confirmatory PCR. You'll review again at 2 weeks and at 1 month. And at 1 month, you're going to start the cotrimoxazole prophylaxis and then also change the medication. So the next slide here, you would change the nevirapine to the lopinavir, ritonavir, and the zidovudine to abacavir. And yeah, so you need to, and then be checking their weights all the time. So that's the issue, obviously, with neonates, is that they change their weight regularly. So to ensure that you're changing the dosages based on their weight changes. Like I said earlier, if they're not growing well, then they need to be assessed for failure to thrive and discussed with a specialist. At 6 months, you're going to do a viral load. If it's suppressed, you're going to continue on the same regimen. And then if it's detectable, you'll continue with the same regimen as well, and then do adherence, strengthening, review monthly, and repeat again. And if it's still not suppressed, you're going to need to refer that patient. So the next one just has drug dosing. So obviously this is really useful because they grow very quickly. And then the next section is about monitoring. So there's 4 M's in monitoring these patients. The first is to determine clinical response to the treatment. Second is to determine the virological and immunological response. We look out for side effects, and also to ensure that they have the sufficient psychosocial support to manage the disease. In terms of determining the clinical response, the important things to remember are growth and neurodevelopment, and to adjust the dosages according to their weight. So just the normal things of when you see a child in primary care is to checking their road to health card, looking at their charts and so on, making sure they're meeting the developmental milestones, always screening for TB and opportunistic infections, and then to do the WHO staging. In terms of virological and immunological response, Elaine, I'm not sure if there's a delay, or it might be from my side. Okay, there. So we do a viral load at month 6, month 12, and then if they're suppressed, you can do it 12 monthly, and we'll get onto what to do if they're not suppressed. And then you do a CD4 just at month 12, and then 6 monthly until you stop cotrimoxazole preventive therapy. So if the viral load especially is suppressed, it's, in this case is below 1,000, you can stop testing the CD4 count. But if their viral load is above 1,000, then you need to continue the 6 monthly monitoring. And then for side effects, these are the main ones. So obviously in older children, the ones that are over 35 kilograms, over 10 years that are on tenofovir, you need to be testing for renal dysfunction as a result of tenofovir. You can look for protease inhibitor induced dyslipidemia, and then also anemia, specifically for the kids on zidovudine, anemia and neutropenia. The next slide. Okay, just to remember that there is also this lack of a hypersensitivity. It's very rare in our population, the mutation that causes it, but you need to, if you do see these symptoms, do think about this. And these are kind of 5 groups of symptoms. So if you have symptoms in more than 2 of those, or at least 2 of those groups, and the child is on a back-over, then just remember to think about this as well. In terms of the renal function, just remember that on the lab form, on the NHLS lab form, that MGRD equation is for patients over 18. So between 10 and 16 years, if you're considering switching those patients from a back-over to tenofovir, that you need to work out the EGFR using the Conahan-Barrett formula. And it's not an EGFR of over 60, we want over 80 for tenofovir use. Okay, in terms of managing the viral loads, if it's less than 50, that's great, that's suppressed. We just continue routine 12 monthly monitoring. Then it obviously becomes more complicated if they're not virally suppressed. So if they're anything over 50, you need to do the ABCDE. So I'm not sure if this was also covered last week, but the first thing is adherence. So you thoroughly go through adherence issues, and to remember taste is one of the important things in children, the taste of the medication, which Isha will talk a little bit more about later. You want to know about bugs, if they have intercurrent infections, especially TB. And for example, if they've started TB treatment, has their ARV dosages been adjusted? And C is also incorrect ART dosage, which I think is also very important in children because their weights are changing all the time. So to make sure that you're giving the correct dosage for the correct weight. D is drug interactions, and then the last thing is resistance. So we're not immediately thinking about resistance when they're not virally suppressed. Okay, so you go through all of these, Shane, this is very small, but once you've gone through the ABCDE, and especially focusing on the A, you're going to repeat the viral load after 3 months. If they're less than 50, great, you continue the 12 monthly monitoring. If between 50 and 1,000, you must continue again advanced adherence support, and then you can repeat the viral load in 6 months. If they're over 1,000, it actually differs depending on what regime, which sets of ARVs they're on. And the reason for this is that dolutegravir and the protease inhibitors have a very high genetic barrier. We did talk about that earlier. So resistance develops very slowly. So an elevated viral load on those drugs is more likely to be due to adherence issues than to resistance. So we generally say that they have to be on dolutegravir or lecanemab ritonavir for at least 2 years before considering switching to second-line treatment. But yeah, so that's why there's a difference between the NNRTI-based regimen, where you only need 2 consecutive viral loads over 1,000. For the dolutegravir PI-based regimes, you need at least 3 occasions over the course of 2 years. Okay, so this is the second and third line regimens, but I'm not going to go through this and read all the drugs, mostly because children who are failing treatment need to actually be referred to a pediatrician. Just some of the things that maybe are interesting is that dolutegravir, there's been a study, it's called the Dawning study, showed that dolutegravir achieved viral suppression when with 2 NRTIs, and only one of them needs to be active. And they think that it's possible that even neither of them need to be active, but there's no conclusive data about that. And yeah, that's it. Okay, in terms of TB, just to remember that rifampicin causes problems with other drugs. So if they're on rifampicin, I'm not going to go through exactly what you do, but if they're on nevirapine, lopinavir, ritonavir, or dolutegravir, they're going to need dose adjustments. And there's different ways to adjust depending on which regimen they're on. This is just a table with lots of tiny little writing, but it's just a dosage table to refer to, and obviously not going to go through that now. And then this next table is a really nice one. It shows you what the formulations are, and also if you're allowed to like split them or crush the tablets if the patient isn't able to swallow. So for example, like lopinavir, ritonavir, if you're taking the tablets, so there is Calitra, which is a solution which doesn't taste very nice. But if they're taking tablets, they need you can't crush them. It's not going to work. The same applies to ritonavir tablets, the atazanavir capsules, and efavirenz tablets. So just to make sure that they are able to swallow pills before you prescribe them those pills.
All right, so I'm just going to go through some child-specific issues and some ethical issues as well concerned with pediatric HIV. So as my colleagues have mentioned, taste is a big consideration with pediatric HIV adherence. Calitra is it's terrible. It's a terrible tasting thing. I have tasted Calitra and it's one of the worst things I've ever put in my mouth. So just also to consider that it does impact on adherence for the children. You can teach the mom how to give it in ways that the child might be receptive to. So you can mix it with peanut butter, try mixing it with food, and just giving something to cleanse the palate as well after that taste. I know peanut butter usually works really well for that. And just as Zahra also just mentioned, other tablets can't be crushed. So lopinavir, ritonavir, some tablets cannot be crushed and will need to be swallowed whole. So it's essential to consider that the child can swallow fully before you prescribe efavirenz, so particularly the foam-coated tablets, or things like lopinavir, ritonavir, if you're not giving Calitra. And then so the two big things here from this slide, I think the biggest take homes for me would be remembering that children are very dependent on their caregivers for survival and adherence. So it's very essential to continue to be advocate of the children because they cannot advocate for themselves, and to continue ongoing support for the family, the caregivers, in terms of managing their adherence. And there's also a few ethical issues concerned with that I'll touch on a little bit on the next slide. And then also just to remember that adolescents are a big category for vertical transmission in terms of pediatric HIV. So they're at that life stage where they've identity versus role confusion, that Erickson life stage, and so they're coming into their self-identity, self-awareness, and discovering their place in the world, and they have to factor in this lifelong illness that they have, and always consider managing the constant threat of survival from HIV, in addition to figuring out the identity. So a lot of that in that stage, a lot of the time you'll find patients with treatment fatigue, and not just the patients, and as well as their families. So it's always important to continue to understand that that is a very sensitive age group in terms of HIV treatment, to continue to provide support, involve psychology, involve social workers, and use a multidisciplinary team to manage HIV in this age group in particular, for those main reasons, and also just to not be hesitant or shy about discussing the issues around coitality or commencing sexual activity, as well as contraception, and the constant risk of teenage pregnancy, as well as horizontal and vertical transmission. Along with that, with adolescents with HIV, it's a very sensitive topic, but it's incredibly important to discuss to manage the disease, to manage the conditions in these children. So now just to talk about some ethical issues. So we've had an ethical discussion around some of the issues around disclosure with HIV as well, but just to remember that Autonomy versus beneficence plays a big role in terms of HIV testing and disclosure with the parents. So the Children's Health Act maintains that parents or caregivers cannot refuse to consent for medical or surgical intervention or testing in this case, unless they can provide a suitable medical alternative. Of which, if you strongly suspect that the child is potentially HIV infected and is responsible for the clinical picture before you, the South African Constitution protects you in that the child's best interests are always paramount in every matter concerning the child. So even if the parent does not want to provide consent for HIV testing, there are avenues you can explore. First-year seniors, senior MOs, clinical managers, superintendents, and lastly, the children's court, if you're struggling to get leeway in that matter. But at the end of the day, you have to manage the conflict between the mother's autonomy, the child's autonomy, and the outcome of having the best interest of the child at play. Non-maleficence is another very tricky one, because you always have to consider the safety of the mother and the child, with considerations of intimate partner violence, as JP mentioned in the previous presentation, and also the risk to the child of violence from the mother's the caregiver's partner, or so could be husband or wife. Should they become aware of this child's HIV status, and then also just to consider discrimination and stigma, which also plays a bit with justice along the lines of other psychosocial stresses there. Understanding that patients might already have other psychosocial stresses that are weighing them down. So considering in this country the racial history of the country, considering tribal nationality discrimination, xenophobia, tribalism, and other things that might make the caregiver or the family aware, or rather averse to the medical fraternity. So education status, mental health, previous experience, etc. But always trying to not cause further harm, and consider and weigh the benefit and the good in that situation. And also another important thing is to consider the future relationship between mother and child, in terms of the child blaming the mother for either not disclosing or having them, or being the reason why they became HIV infected. So that's a very sensitive matter to always have in the back of your mind, and always try to manage as well with your consultations. And then the last point would be the concept of justice with managing further transmission. Managing the patient's autonomy, but versus the benefit of the greater good, in terms of curbing the spread of the virus via horizontal or vertical transmission. And yeah, the last thing we have are a few resources to help.
Yeah. So basically, if you've forgotten everything we've said today, the most important thing to remember is follow the guidelines. The 2019 guidelines, we'll post them on the group. We've spoken to some doctors that run HIV clinics. For example, the primary healthcare clinic in Witkoppen has between 95 and 99% viral suppression rate, and they don't have any tips or tricks. They basically just said that they follow the guidelines very, very closely. Also, the PHC nurses, they're extremely knowledgeable. Go and speak to them, go and ask them questions, go and have a chat to them. They know exactly how to speak to children, how to speak to the families as well. And I know it's not something that we get exposed to very often. So definitely go and have a chat with one of the PhD nurses. EM guidance is always great. It has all of the protocols on there. Sometimes it's not very easy to use, but there is another app which I definitely think everyone needs. It's very user-friendly and it has quick access to all of the guidelines. This is what it looks like. It's the the HIV/SA/HIV/TB hotline. So this is what it looks like. So it's very user-friendly, like I said. So here you'll just log in or whatever. Then let's say you want to look at drug interactions. You'll click on drug interactions, and let's say I want to check whether we know now that rifampicin and dolutegravir interact with each other, but let's say I didn't know. You would tick dolutegravir, and then they'd ask you, what do you want to see it interacts with? You put in rifampicin, and it comes up, says yes, there is an issue. Yes, there is an issue, and it explains exactly what the interaction does and what you should do in the case, in that case, that there's an interaction. So I think definitely go and download this app. It's very user-friendly. It has all of the posters on there. It has all of the protocols on there as well. So it's very easily accessible if you're in a bit of a bind. And that's our presentation. These are our references. Thank you very much, everybody.
Thank you very much. Thank you to both the presentations. It's always great. You guys do a wonderful job and also share some very useful resources that we don't pick up on ourselves. So wonderful. Thank you very much. I think if we can give them a sense of how well done. I don't know why my... Okay, I think that sounds great. Thank you very much. I don't know if there are any other comments or issues that, yeah, I think Dr. Petkov has got my hosting. I thought she'd be able to do it. Let me just quickly see if you can give some feedback. It's your way of saying thank you and giving them a clap. So if you could just quickly give them some rating. I think both the groups will probably take this and use it. So it's our way of saying thanks to you guys. So lots of goods and very goods. Well done. Really appreciate it. Any questions, comments? If you want to raise your hand and ask for any comments or questions, I will put the recording and the resources out on the web page and provide any other things that that the groups provide us. So well done. Thank you. Great resources that you pointed to. Okay, the guidelines are there. So I think the end statement was follow the guidelines closely. A lot of the problem in primary care is a lot of doctors seem to be very reluctant to manage children, which is unfortunate. Mostly these older doctors like me who are lazy and don't read enough. Right. Well, thank you very much. Great stuff. We'll post it out there if there seem to be no more questions. I don't know if there are any closing comments from any of the family physicians who are on the call. Dr. Petkova, Kabir.
Wonderful presentations. Well done to the presenters.
Yep. Good. Thank you all. Take care. And let me just share the poll results so you can see that. Nicely done.
Good. Thank you.
Bye-bye, everyone.
Bye.